So welcome everyone to the STS Intermacs and Pedimacs Reporting and Users Group webinar. My name is Catherine Holyfield. I'm the STS National Database Manager for Intermacs and Pedimacs. And today, as mentioned earlier, we're having a joint webinar. We're going to feature reporting to recover the reports and new features in the reports and upcoming ideas, and also the user group webinar. So at the end, we'll be able to take some questions, whether it's about version 6.0 or if you have reporting questions. We're happy to answer them. So we'll go ahead and get started. Again, my name is Catherine Holyfield. I'm the STS National Database Manager for Intermacs and Pedimacs. Just want to go ahead and welcome the team that we have joining us today. I've got to replace this. I'm sorry. We have Patricia Plotter, who is replacing Janella Miller. So she will be a new contact at UAB, the Intermacs Data Warehouse, for questions regarding Intermacs data entry. We have Jeannie Ann Love, who I think is on the call today. She's our Patient Management Director. We have Dr. Ryan Cantor. He's the lead statistician and Director of Reporting at the Intermacs Data Warehouse. Maceo Clige, he's one of the clinical data analysts, and most of y'all interact with him in regards to your report and reporting verification and confirmations, which we'll get into later. We have Mr. John Pennington, who is our Intermacs Data Warehouse Senior Data Manager. We also have Devin Cole joining us today, who is a Senior Analyst at the Intermacs Data Warehouse. And from STS, we have Leanne Jones, who's the STS National Database Manager for Congenital and General Thoracic Surgery databases. And we have Carol Crone, who's the Senior Clinical Manager for the STS National Database. So as mentioned earlier, this is a joint webinar. We have the UAB reporting teams joined us today. And so they're going to go over some features on the reports and some upcoming ideas. And then if we have time later, we'll take some version 6.0 questions. Any questions that you'd like to ask, you can put in the chat feature. And I believe that's it. Ryan, Dr. Cantor, would you like to take over now? I will
Sure.
stop here so you can go ahead.
Great. Thank you, Catherine. Well, thanks everyone for joining today. And I look forward to the opportunity and the chance to walk you through some of our recent changes in the Intermacs QA reports that we rolled out this quarter. Those distributions happened at the end of December. We have a few planned report additions that are planned to be distributed in March. So I want to review some of the planned edits that we have there. And really the goal of these edits that will go out in March are addressing several of the immediate requests that we've had over the last 6 months or so. At the end, I want to go through some of our longer term plans. We just want to think about how we can continue to enhance the reports, but also maybe even focus them in a way that makes them more consolidated, but that still meets everybody's needs. So, over the next few months, we'll be soliciting input from people. And I think this forum is a great place to get feedback and to talk about things even before we implement them. So one of the big changes we made in the Q3 reports is we shifted the recent year report from 4 quarters to 6 quarters. And we had a couple people ask, well, why did we do this? So I just wanted to walk through our thinking and why we did that. When we used a rolling 4 quarters, very few patients were actually at risk right at the change of the year at 12 months at risk. And so many sites didn't get a 12-month estimate here. And by expanding to 6 quarters, almost everyone will have that 1-year estimate in really all the Kaplan-Meier exhibits. But that we implemented that and rolled that out. So if you didn't notice, we are now using a rolling 6 quarters on the recent report. Other modification we rolled out was to include several new exhibits that stratify your center versus the overall aggregate, but limiting each plot, each Kaplan-Meier plot, to a specific patient profile, profile 1, 2, 3, and then we grouped 4 and above. So this is data from Hospital X, a random collection of 100 patients. So you can see, I just screenshotted what these Kaplan-Meiers look like. You can see that, overall aggregate profile 1 patients do a little bit worse than the less severe severity of illness patients. And at your center, you'd have all these comparisons. And these plots were rolled out in the entire collection of reports. So, if you're interested in seeing patient profile 1 in all of your patients, you could look at the cumulative primary VAD patients if you want to look at all your primary VAD patients, or the prior VAD, or a more contemporary cohort, and limit it to those rolling 6 quarters. And those exhibits do have the estimates with the confidence intervals. So if you want to, pick a point in time and compare within your site or within the aggregate, you can pick specific time points off the plot, and it provides those estimates. So that went live this quarter. We had several folks requesting Kaplan-Meier by patient profile, so we hope that helps. So that was all the edits we made last quarter, and we've started working out our list for things that are in the queue for 2020 quarter 4 that will be distributed at the end of March. And many centers have requested just one report that includes everybody. So we're finally at a point where we're just going to add 2 more reports to this collection. One will just be all patients over all time, and one will be patients, based on the recent, rolling 6 quarters. But it's not going to be broken into primary versus prior history of VAD. I know we throw a lot of information at everybody. I know some people, this report will help based on what they want to report, and other folks, might be happy with the reports that are already provided. But I'll circle back to this idea of how we can begin to consolidate some of the reports and what some of my initial thinkings are. But look for this comprehensive report, these 2, starting next quarter. This is a minor edit. We had some requests for a little bit more information on the patients that are Exhibit 49, where patients that are implanted at your center but excluded from the analysis. We're going to add implant year to that exhibit. Some folks said they would find that helpful, so we're happy to accommodate that request. Another modification is we're going to adjust how, and this is a minor, this won't affect many patients, but we're going to slightly change how death on a device is reported. So currently patients are censored at cessation of support events. So when the device is explanted or turned off, that stops their main Intermacs follow-up, and they're censored. And what that means is that those patients are given credit for surviving on a device, up until that cessation of support. But we don't count them as a death or a transplant or anything else that happens afterwards. We just say, we don't know what happens afterwards in the current analysis. But in reality, we do know what happens to some of these patients, because we collect death date and transplant date if it happens within a year afterwards. And so our plan is to update, and this was at a few sites' request. Our plan is to update this reporting so that if a patient expired within 1 day of that cessation of support event, then we're going to go ahead and plot it out and report it as if it were a death on a device. So we won't censor those events. We'll count them as a death on a device. I don't think this will affect many patients, but it may be a more accurate reflection on what happens to those patients at the time of withdrawal of support. With the change to version 6.0, The reports will stay the same on almost all of the exhibits. There are a few exhibits, namely some of the more comorbidity data collection changed slightly with the version 6.0. And basically, we're going to map the reports to how the data is collected now. And so many of the exhibits, around comorbidity, the data has been mapped, they'll still be there. But if some of the data collection is no longer supported in version 6.0, then those exhibits are going to come out of the reports. And like I said, I think this will be a minor change. We'll be working through that over the next month. So, but we should have the reports aligned with version 6.0 by this Q4 distribution. And a minor housekeeping note on our end, we're going to change from using WinZip to 7-zip at UAB IT's request. That's kind of a UAB IT mandate. They've said we can't use WinZip anymore. We've tested this within the DCC and we don't anticipate any issues, but I just wanted everyone to know that that change is happening. You should be able to still unzip your packets just like you always do. But if you do have any issues, know that we've made this change and reach out, so something will have changed next quarter.
Hey, this is John. So if I can chime in, if you do have any issues, most likely the simple solution is that you don't have 7-zip installed on your machine, and that will fix it.
Thanks, John. I want to mention just briefly what's been going on in Pedimacs report. We haven't made any major revisions. I think maybe 2 or 3 quarters ago, we really expanded the information in this report so that it covered all pediatric devices. There's a cumulative and a recent rolling 6-quarter report. But since Pedimacs collects both temporary and durable devices, we report out both of those. And we have a section of report tracking outcomes on temporary devices and a section for patients who start out with durable devices. So I don't have any planned edits for Pedimacs, but of course, if we have any Pedimacs users on the call, we welcome any feedback or comments on those reports. And finally, I just wanted to mention a couple of ideas I've been having about kind of longer term plans for the reports. And these are kind of early ideas I'm talking about with Catherine and the STS leadership, trying to come up with a more formalized process for how we make sure the most clinically relevant information is included in the reports, and a strategy for consolidating the information there. So right now, there's been a long history and evolution of the reports, both before STS acquired Intermacs, and now under STS's leadership. And pretty much all of the individual requests for centers from centers have been, reviewed, and where possible, we try to incorporate all of those requests as soon as possible. And typically, there's not really an avenue for information to be removed from the report because somewhere someone seems to use something, and we haven't had a real strategy for making sure that the most targeted information is there. So the benefit of this is we have a lot of information in the reports, and like I said, every time we get a request and a different kind of view of the information, we're happy to try to accommodate this. But I wonder sometimes, is this too much information? What measures are the best to use? Are there ways we can consolidate this into a core set of comparisons? So ideally we would love to get continual collection of feedback and ideas, but maybe we can plan for one annual edit of the reports that is approved and guided by senior STS leadership, and really try to target the benchmarking here for a more succinct depiction of the information. And this might also be facilitated by our outcome analytic tool that's under construction. This is one of the top priorities for our team this year, is to actually roll this out. And just to remind everyone, what this outcome analytic tool will allow you to construct a lot of the kind of user-defined Kaplan-Meier, outcome and patient characteristic outcome. It's an extension of the cohort comparison tool. So you'd be able to say, let me see all of the profile 1 patients that were implanted in the last 2 years, and then see your center versus all of Intermacs, or compare profile 1 versus profile 2, post-transplant, post-implant survival on a device at your center. So, as we roll out that tool, and with some, focused input from STS leadership, I think we might be on a track to consolidate these reports. But, through this process, everybody's feedback will be really helpful. Any information on, exhibits that are specifically useful, and even feedback on exhibits that get in the way of finding useful information would be really helpful. And this and other forums will be really critical in those discussions. And, I can imagine we will, have a webinar or some discussions before we start really rolling back, just to make sure that we keeping changes in line with what's most helpful for the sites. So that's all I had for today. I can turn it back over to Catherine if you're ready.
Yeah, thank you, Ryan. Thank you for your presentation. So I really appreciate that. I appreciate you giving us all the potential updates on the report. The next thing I did want to talk about, Ryan, as you had mentioned, the outcome or the Kaplan-Meier, will that be in a report form, or has there been any discussion about this maybe being possible on a dashboard so sites could get it real time?
So we're actively working on these tools at the DCC, and this might be rolled out in a phased manner. So, currently all of our QA reporting is based on these research builds that are updated quarterly, and that's served very well. That allows a comparison with an aggregate where all centers have this grace period for entering in the data. And if I were doing a research project, this would be the data that I would want to use for that research project. In fact, this is the data that we use for all of the projects. However, in talking with sites, over the last few years, I've realized having that real-time component is incredibly useful, especially as people get data caught up, and depending on when the Joint Commission visits are. So we will want to have an option where you could say, use the quarterly build, or use the live data. However, I don't want to let any of the technical hurdles that allow us turning this on in a way that can make the curves that you currently get in your QA report. Like, as soon as we can get that on, I want to turn that on. And the idea is that, you select the cohort, and then it delivers to your screen the curve as an image that you can print out or, view on the computer. But shortly thereafter, we're on a track to have something that's uses the real-time data, and that might allow more interaction in terms of, maybe you want to adjust the titles, or zoom in on a section, or toggle features or confidence intervals off or on. So we're certainly moving in that direction. I don't know if that answers your question or not, Catherine.
Yeah, I appreciate it. Thank you. Would you mind kind of talking or explaining the main difference between the currently the sites receive for the recent reports and the cumulative report, and then there's the prior VAD report. Would you mind quickly explaining the difference between that report and then your the good old regular QA report for Intermacs?
So, so some patients are enrolled in Intermacs without a history of prior VAD support. And this is how it's collected on the pre-implant form. So this is all triggered by what information is on the pre-implant form. And so, you know, early in Intermacs evolution, that prior support before their first Intermacs device might have been durable or it might have been temporary. And unfortunately, a limitation of the data collection at the time, and up until, you know, November of last year, we didn't ask for what type of support the patient had prior to getting their VAD, their first Intermacs VAD. So some patients would be enrolled in Intermacs with I'd know that they had a history of a VAD, but I wouldn't know whether it was a durable or temporary VAD. And that could, if it was a prior durable VAD, the patient outcomes for that collection of patients would be quite different than a patient that's arriving at Intermacs with a history of a temporary VAD. And so early reports in Intermacs only focused on patients whose first Intermacs device was a durable VAD without a history of any prior support. And the reason I had to exclude any history of prior support, LVAD, RVAD, TAH, was because we didn't know if it was durable or temporary. And you know, the data collection, we couldn't distinguish before it. And it didn't seem fair to lump all of those patients together into one report. So to facilitate a, you know, apples to apple comparison as much as you can in this kind of pretty heterogeneous group of patients, you know, we limited the reports to primary prospective VADs. So,
Okay.
so since then, you know, we really wanted to provide reports on all patients. So, you know, the evolution of my thinking was to, well, let's just break it out into two different reports: primary VAD patients versus patients that have a history of support. So that's one distinction. So your patient should be in one of those two. And like I said, we're finally at a stage where I'm just going to create a report that has all of those together. So that's kind of one factor. Like, did the patient have prior support before their first Intermacs device? And so that the answer to that question will route that patient's information to one of these three reports now. They'll either go into, well, all patients will go into the comprehensive report, but the patients with a prior VAD go into one. Patients without a history of a prior VAD, meaning it's a primary VAD, will go into to that one. So that's kind of one factor. And the other factor is the timing of that implant, which is whether or not it's over the course of all Intermacs data collection, or if that implant, that patient's first implant occurred within the last rolling 6 quarters. So it's really just depending on what question you're trying to answer. You know, if you want to know, if you're interested in looking at primary VADs, you know, in a contemporary cohort of patients, you know, I'd recommend looking at your recent year, you know, primary VAD patient. If you're interested in looking at all your patients over all time, I recommend using the comprehensive cumulative report, you know, that we'll be generating and distributing next quarter. So I don't know if that confused or helped, but
I appreciate that explanation. Thank you, because I know that's a question that's frequently asked. Thank you for your time today. Let's see, I'm going to go ahead and let's see if we have any questions in regards to the reporting. Oh, and it's a good thing, Devin. This one would be for you. Is there a way to filter live data download reports by type, or will they consider adding that filter in the future?
Yeah, so I read that question and I was just trying to get a little bit more information, because I know that we do have the device type on the implant form, But are we talking about, because currently, if you wanted to say that you wanted to merge together the demographics and the implant form, you have to do all that complex merging within Excel. So I was trying to understand if they were talking about device type in a different place, because currently it's just collected, like if you were to download the implant live data download, it would be one of the columns, device type. And so it's on there. So I didn't know if there was like another form maybe that they're wanting to add it to. But if we are considering that, any suggestions, I'm happy, you can email them to me and I can pass them along to, one of our software developers who actually works on that. So we can make it definitely more user-friendly. Any suggestions, I'm happy with.
Okay,
And can
Thank
I
you.
jump in here too, just a little bit?
sure.
And I think, the main goal of the live data download is so that sites can, within a snapshot, download all of the data that they
Right.
have. So what Devin is suggesting is from that, it's a little cumbersome, but not too bad to limit, to put a filter within Excel. So I might suggest, Devin, that we like write out how to do that. And
Yeah.
then I think that would be the fastest way to get to that and keep the live data download kind of true to its core intention, which is to quickly facilitate the download of all of your data.
Right, and then you could go to and so the way that you could do that, I could definitely think about, going to the implant form and just filtering, seeing whatever device that you need, but you can definitely find it there.
Right.
And also, I just wanted to mention that also if you want to download the report for LVADs and RVADs separately, you can do that on the cohort comparison tool.
Oh my gosh, I didn't know Rama was online. Well, speaking of.
Yeah, so thanks, Rama. Thank you for that. While we have you at today's webinar, Rama, as he actually does the programming, so he is basically the director of the programming. So all these updates and everything that you see in the database, that's Rama's product. So very talented, and we're very lucky to have him. I know that we've discussed about getting the 6.0 elements in the live data downloads. Do you think that's something that'll be available probably in the next month or two?
Yes, Catherine. So we are working towards February 15th to have the 6.2 changes in live download by February 15th.
Okay, great. Thank you.
Yeah, no problem.
So the next question is the CMS, their national coverage decision that came out in December 1st, 2020 indicated we no longer need to indicate intent of the LVAD such as BTT. Is this something that will be removed from Intermacs, or do we default to DT? Heather, this is a great question. Actually, the Intermacs task force, which is chaired by Dr. Pagani, this is something that I will take to him and have them discuss this. I believe they've been looking at this. They're aware of this. So I'll have to go to him for his guidance on this question. But thank you. The next question. Hello, why are edits/reviews only planned to go to annual? That's a long time to gather data only to have it deleted or new elements added. And Cindy, I'm assuming you're talking about the reports. Ryan, I don't know. Devin, is that what you gather, that it's a reporting question? If you could just confirm that you're talking about the QA reports, that'd be great, Cindy.
Hey, Catherine, this is Carol.
Mhm.
On Cindy's question, I just wanted to clarify that we're not doing data version upgrades annually, correct? Or is that the plan?
No, I believe she's talking about something in regards to the QA reports going what Ryan was just discussing, having them on a yearly basis or showing annually. I'm not for sure. That's why I wanted her to clarify. Is she talking about the reports? Because yeah, the version upgrades are only every 3 years.
And she says QA reports down at the bottom there.
Yeah.
Right. And so, we're working out the process in annual or whatever time frame we talk about. I think my intention from that comment was to say we need a formal mechanism where the clinical expertise of the STS leadership are periodically looking at the reports and helping guiding the direction that they're in terms of report enhancements and report consolidation, and how to best prioritize some of the conflicting but all good requests that we're getting from the different sites. So, and there's a lot of information that's collected in the database that is not immediately used in the reporting that is, useful for other types of queries and analyses done from the database. So, the presence or absence of things, although we certainly want to include the most important things and as much as is feasible in the reports.
Thank you, Ryan. Our next question, our psychiatrist had a few questions regarding definitions for comorbidities. How do you define poor social support? Also, it has that chronic alcohol abuse contributes to liver dysfunction. Not everyone with alcohol use disorder has liver abnormalities on labs. Is this a definite indicator? And Heather, we're actually, I'm actually still working with Dr. Pagani and the task force, because that's one of the things we wanted, because that the comorbidity section, we really wanted to provide guidance to the data managers. And so there are a handful of questions, and these are a couple of them that don't really have any guidance with them. So we're still working, updating and providing some guidance to the data managers on those. So those will be, there will be some data entry tips on those coming out soon. I can say offhand, I do know that they're leaning for the defined poor social support, meaning that if the patient doesn't have, if their family is not supportive or really able to take part in their care, they don't have one supportive in the home that can help them with their care. I know that that's one part of it. And the next question, Ryan, it looks like this is probably for you. I'm trying to understand the survival percentages associated with patients being censored at transplant. Example, 16 patients, 2 deceased by the 6-month mark. And then you've got the nominator and denominator would equal the 88% survival. 1 patient then transplanted by 1 year mark. What would the survival percentage be at 1 year? And then are you going to removing this patient from the numerator and denominator?
This is a good question that kind of gets at the crux of why we use Kaplan-Meier survival analysis in addition to just reporting out the absolute observed percentage. So, and we could spend a whole stats lecture on this topic that we won't get into now, but that 14 divided by 16 there is the actual observed percentage, but of survival on a device there. The issue is that you don't know what the survival of the patient would be on the device that's transplanted once they get the transplant. That kind of rescues a patient from death on a device. And so what Kaplan-Meier does, and it's not just a quick calculation I can do on the call here, but conceptually what it does is at each unit time, it says how many patients are at risk. And then in the next unit time of those that are at risk, how many meet the event. So it's out of how many patients have left, what percentage meet the endpoint of death on a device in the next, unit of time, which is, based on, well, it's just the next observed bit of information. So, and then it's cumulative, like these percentages get multiplied up across the way. And the net result of that is for the patient that is transplanted at 1 year, all of their follow-up is in the denominator of those calculations up until the time they're transplanted. And once they're transplanted, they're no longer at risk for death on a device. And so they fall out of the denominator. So it's not as simple as just adding them or removing them to the denominator of your absolute calculation you have there. So the patient is given credit for the amount of survival on the device that is observed, with their follow-up on a device is kind of the most concise explanation I could give on this call.
Okay, thank you, Ryan. Thank you. Ashley, if you need some more explanation, feel free. You can always email me directly, and then I can get in touch with Ryan for further explanation if necessary. The next question, Devin, this looks like it's probably for you. I was thinking of the context within rehospitalizations or major bleeding reports within the live data downloads. We have interest in tracking the outcomes for HeartMate 3 patients, since that is what we are primarily implanting now. So Shelley, are you wanting to work with the live data downloads? Or are you talking about, I believe this is in relation to the device type question that we've had earlier. But Devin, since we're on the topic of the live data downloads and adverse events, rehospitalizations and major bleeding events, sites can download those events, correct, and make graphs and pie charts and see what percentage of their patients implanted with the device brand.
That's right, Catherine. There's a separate data download for both the rehospitalization form and also the major bleeding form.
Okay, great. Thank you.
Can I ask a question of our team and make a comment right here too? Because I'm looking at this question and I'm also jumping down to Heather's question on, can you add implant date to all data downloads?
Right.
So what I'm wondering is, on each form, where appropriate, it has the event ID, which is our variable name for the unique device ID in the system. And so each of those, devices has an implant date, and each of those devices have a brand. So it's conceivable that on every form download, we put the implant date and the device brand of what was in place at the time of said event. We'd have to talk to.
That's actually a good point, though, because on form downloads, we have those standard variables that are always on every single one, and we could add that as part of them.
There's a ticket that's in the works right now on the stuff that Rama and his team are working on. I know the implant date because I submitted that ticket. The device brand stuff, I don't know, but yeah, that could all be part of that header info, and that's why we like this kind of feedback. To kind of wedge in here too, though, like we do have the site data sets that are uploaded. So I know, Shelley, if you're needing like up to the minute data, this isn't going to work out for you, but the merges that you're looking for are already done for you in those data sets that I upload each quarter.
Well, thank you. Thanks everyone from the Intermacs Data Warehouse and UAB on the call. This has been really helpful today for everyone's chiming in for their section and can provide answers. And then we have a question from Curtis. Is there a way to automate file transfer via secure file transfer for Pedimacs patients? And then Curtis, if you're still on the webinar, are you talking about kind of doing like a data dump for your patients into Pedimacs? And then if you could just respond to that, or you can email me later. I know at this time Pedimacs is not working with vendors. It's not really in discussions. But if you want to email me directly, I'm happy to discuss this further.
Oh, I
and
see.
then-
He just chimed back in from Pedimacs to their hospital. So
Oh, from Pedimacs to my hospital.
I don't know what the different. I mean, like through the form download, that literally is all of the most granular data, like at the moment. So I mean, if you went and clicked through all of the form, you know, it's probably like 15 different. So so do you want like one button, you get all the Excels?
I want no button. I think he's just wanting to know, yeah, if he can just do
Like
like
an
that.
automated transfer?
Yes. Curtis, it's probably best if you just email me directly, and then we can discuss your request offline.
I could already see security concerns for an automated transfer because we'd have to have a recipient we knew was there. But yeah, I'm interested in talking about this with Ron and Rama.
And then I know we discussed Heather's question about adding the implant dates to all the data downloads. And I believe, John, you are correct. I know there's a ticket in for this to be done. And then we'll discuss this further, Heather, and see what we can add to the header. And then Christy wants to know, with all the new questions on the implant form, will there be a surgeon worksheet available like STS, ACS? Yes, Christy, I'm actually about to wrap that up, and I am going to have Carol is actually going to just take a glance at it for me before we can post it to make sure we're in the right direction. And Christy also asked, on the comorbidity section, our pulmonary lead is questioning the definition listed right under chronic lung disease. Currently it states defined as mean pulmonary arterial pressure greater than, etc. Is this truly the definition? I will have to get back. I will email you about that. I will have to look up and see the exact definition that we provided. I know in some of these sections, we did try to align with the adult cardiac database. So I will definitely have to get back to you on this one and see what the full definition is. And then Cindy saying, I thought this call would have been about the outcomes reports that came out Monday, considering they're completely different from the last ones and doesn't have some of the things I need. I can't find the multipliers for the risk-adjusted mortality anywhere. Ryan?
I don't understand what's being asked here, because we like, what is this concerning?
Outcome reports? Cindy, are you referring to Intermacs and Pedimacs? Because I know our reports were out. Yeah, I think you're right, Karen. Thank you. Adult cardiac. Thanks, Karen. Because I know the Intermacs reports came out at the very end of December, I believe. So Cindy, I think your question, maybe Carol, you could email Carol about your question.
This is Carol, Catherine.
Yes.
Cindy, those are coming from DCRI, and we will have those posted in the IQVIA resource library, just like we did for the Harvest 1 report from last year.
Thanks, Carol.
No problem.
And then Curtis, what is the best email contact? Curtis, you can email K Holyfield at sts.org, and that's probably the and then I will definitely talk to the team about what your question. Yeah, thanks. So I want to say thank you to the UAB, the reporting team, for actually being on this call. And Ryan, thank you for your slides. These will be posted, and the call will be posted under the webinars. Probably, I would think, if not by the annual meeting, our STS annual meetings this week, so it might be next week when this is posted. Here are some email addresses or just some links to find some Intermacs and Pedimacs resources. This first link is you'll get all things Intermacs and Pedimacs, the appendices and the user's guide and the data collection forms, and the training webinar will be located in this link. And then the next link is going to be any reporting question you can send to this email address right here, the Intermacs reports at uabmc.edu. And speaking with that, one of the things that Ryan went over is all sites receive a data quality report. The data quality report is just that. It's to help. It's just to kind of give a site where they are, how their data is doing, as far as Intermacs is concerned. Most of the data fields or the questions in the exhibits that we have in that report were approved by the task force and thought to be, some of them are risk factors, some are just important factors for these VAD patients. On a few of those exhibits, you will see an exhibit or a table that says wants site feedback, like it wants a site to confirm if the NYHA is a certain number below 4, or to confirm if there's a patient has gone so many years without an adverse event, which in this patient population is very rare, but it can happen. But so I just want to remind sites to look at your data quality reports and complete the confirmations where asked and where it's applicable. And you can send those back to Maceo Cleget at uabmc.edu, or I believe, can they also send them to the Intermacs reports at uabmc.edu also?
Oh, yes.
Okay, thanks, Maceo. And the last link's going to be for the STS website. And that you can find things regarding Intermacs and the webinars, and also for sites that are interested in doing quality minor data requests. Those can be found there. We have a few minutes left. So if anyone has any questions regarding version 6.0, I know we combined the webinars this month. Next month, the whole focus will actually be on version 6.0. It'll be just asking questions and getting everyone's feedback, because everyone should have experience a couple of months of working on that, entering data with the new data elements. I will get those surgeon worksheets posted. And I just want to thank everyone for joining. The next Intermacs and Pedimacs webinars, February 24th, is a Wednesday at 1 p.m. Central Time. And the next reporting webinar is April 18th at 2 p.m. Central Time. So it doesn't look like we have any more questions. Oh, we do have a question. So let's go ahead. Can I email you, Catherine, regarding a question on, yes, right heart failure when entering follow-ups? Yes, Christy, that would be great. Thank you. Can you repeat the next call dates? I cut out. Sure. So the next Intermacs and Pedimacs user group webinar will be February 24th at 1 p.m. Central Time. And the Intermacs Pedimacs reporting webinar will be April 15th. So the users group's February 24th, next month. And that will be all about all things version 6.0. But I appreciate everyone joining today. And thank you. Thank you for taking the time. If you have any questions that you think about once the webinar ends, then feel free to reach out and send me an email. And thanks everyone for joining, and I hope you have a great rest of your day.
Great. Thank you, Catherine. Thank you, UAB.
Thanks, Catherine.
And
Thanks,
thanks
Catherine.
UAB. Thank you so much. Thanks
Thanks,
for all your
everybody.
help.
Thanks for the feedback.
Bye. Thanks.